All right, well, it's 12:03, so I think we'll go ahead and get started. We are so excited to have one of our own Pepper scholars here today. I'm really excited to introduce Dr. Prakash Jayabalan. He is a physician scientist director of the Nancy W. Knowles Strength and Endurance Lab at Shirley Ryan AbilityLab, and an associate professor at Northwestern University Feinberg School of Medicine here in Chicago. His lab's work focuses on using biological markers to develop novel individualized rehabilitation and exercise strategies for individuals with knee osteoarthritis. He is a Pepper Scholar and has received multiple federal and foundation grants. His significant contributions to his field have been recognized in the past year, in him receiving both the Early Career Awards from his national specialty organizations, the Association of Academic Physiatrists, and the American Academy of Physical Medicine and Rehabilitation. So we are so excited to have you, Prakash, and I will turn it over to you.
Thanks so much, Sarah, and thanks so much for the Pepper Center for supporting my research and also supporting me in terms of mentorship and other things I've needed. So today I'm going to be talking about exercise as a biological medicine in knee osteoarthritis. I don't have any disclosures. I'll be focusing in some domains of what my research is focused on. So I'll start initially with the biology of knee osteoarthritis very briefly. We'll talk about the use of some of these biological markers for diagnosis and treatment. I'll also talk about the relationship between biology and exercise, stressing the system, and targeting the right patient at the right time using biomarkers to help with that. So I want to start with a case, and I always start my presentations with a case. And I want to imagine that whether you're a PM&R physician, such as I am, whether you're a primary care physician or a geriatrician, you see a patient in your clinic, 67-year-old former runner who presents with a 7 to 8 month history of medial-sided knee pain. Our classic evaluation in our clinics is to examine them, perform radiographs, and then we diagnose them with osteoarthritis of their knee. Now, the thing that I am really focused on as a clinician scientist is to really see, could we have diagnosed this earlier? What level of physical activity should we have recommended or should we recommend for this patient? And what sort of rehabilitation should we prescribe that's most efficacious for this patient? Now, in terms of treatments, our common treatments include initially managing their pain through analgesic medications such as acetaminophen, NSAIDs. We'll advocate for weight loss, exercise, rehabilitation, physical therapy. We'll talk about probably 2 types of injections, and the only 2 kinds of injections that are currently covered by insurance in the United States are steroid injections or viscosupplementation or hyaluronic acid injections. And that really leads all the way to total joint replacement. And my goal as a non-operative practitioner is to really optimize the left side of the screen to really try and prevent or delay the need for total joint replacement. The other thing that's important to remember, and particularly this happens when I'm talking to trainees of mine and I ask them, what is osteoarthritis? They'll often talk about it as wear and tear within the joint. But if there's one thing I'd like you to take away from this talk today is that osteoarthritis is more complex than that. It's really this idea of abnormal biomechanics feeding into abnormal biology. And you have this vicious cycle that continues that leads to the progression of osteoarthritis over time. So when we think about our treatments, they are dealing with both of these situations. So we think about medications that we prescribe. We're prescribing anti-inflammatories to really decrease that inflammatory cascade that occurs in the joints. There are medications that are being developed that target some of these cartilage degradative enzymes called MMPs that are also present within the joints. We'll also advocate for physical activity in our patients, and I'll be showing some data today that physical activity likely has both a biological effect and a biomechanical effect in OA. And we also advocate for weight loss, which has a biomechanical impact, losing weight, but also has a biological impact by multiple studies showing that systemic inflammation also decreases with weight loss. The other part that's often forgotten about is that the knee joint is like any joint, or like any organ in our body, is that it is an organ. It has multiple structures that coalesce in a membranous structure to actually to coalesce to form a structure which actually has function. And the function of the knee joint is to allow movement. So when we think about the knee joint and most treatments that are being developed, they're often focused on cartilage breakdown. But we know that there are other parts of the joint that are impacted in osteoarthritis. So we have the synovium, which is shown in pink here, which is that membrane that surrounds the joint. It's bilayered, it produces hyaluronic acid and also other nutrients which actually go into the synovial fluid, which bathes the cartilage. So that's really important for cartilage health. We know the synovial fluid is also really important. Studies have actually shown that joint fluid is more acidic when individuals have osteoarthritis as opposed to healthy joints. We also know that the subchondral bone is really important. That's the bone underneath the cartilage. And studies have also shown that when the subchondral bone is damaged or diseased, that actually impacts the cartilage above it. And there's this crosstalk between the two that's normal and healthy, and that's impacted in osteoarthritis. And finally, of course, there's the articular cartilage, which is avascular and alymphatic, which is one of the major issues when we're thinking about osteoarthritis development, is that it has very poor reparative potential. And also it's aneural. So when an individual has cartilage that's thinning, they don't know about it because there's no pain that's associated with that until there's bony involvement because the bone has some nerve supply. So what happens is in normal joints is that there's this optimal balance between catabolic processes and anabolic processes that are occurring in the joint. But what happens in osteoarthritis is that we know that there's damage to the articular cartilage, such as the patient bears weight over time, there's damage to different parts of the joints that we see structurally on MRIs or may even see on X-rays. And over time, there's potentiation of that joint cartilage damage by the release of some of these inflammatory mediators and cartilage degradative enzymes. And eventually, there's bone-on-bone motion that leads to joint pain. And so when we're thinking about the knee joint in osteoarthritis, that balance gets tipped more towards catabolic processes as opposed to anabolic processes. So with that knowledge, how can we use some of these biological markers to improve some of our diagnostic and treatment modalities that we prescribe for our patients? So one of the major problems right now that we have in OA management, which has been the case for about the last 10 to 20 years, is that we don't have a way to diagnose osteoarthritis early. Radiographs, for example, if you do them in clinic for your patients and you see osteoarthritis, the cat's already out the bag. They're quite far down the line in terms of their osteoarthritis development. MRIs, we rarely ever advise for those for osteoarthritis diagnosis because they're expensive and they don't really give us information on the pain generator in the joint. And finally, arthroscopy, that's really gone out of favor. In the old days, you may even still have patients who talk to you about, oh, I had an arthroscopy and the surgeon told me that they washed out my knee joint. Well, that's not actually shown to have a good outcome. It's expensive, invasive, and even from a scientific standpoint, with arthroscopy, you're only looking at the surface layer of the cartilage. You really don't know the biological health of the cartilage when you're just looking at it on an image. And overall, all of these modalities have limited correlation to symptoms and function in our patients. So when we're thinking about being a physician scientist in osteoarthritis, can we be a fortune teller? Can we look in our crystal ball and be able to tell someone that either they're developing osteoarthritis or how are they going to respond to our treatments and be able to tell them how their osteoarthritis is going to look like 5 to 10 years down the line? And in turn, can we intervene earlier because we diagnose it earlier? So more towards the bottom part of the screen, less so towards the top part of the screen when someone's needing total joint replacement. I know it's lunchtime, so I'm sorry to get a little bit as scientific here. But obviously the whole talk is about science, but this might bring some memories back from your step one back in medical school. But what I want you to remember is that cartilage consists of a chondrocyte surrounded by an extracellular matrix. So the chondrocyte is the big circle, white circle here in the middle, and it's surrounded by an extracellular matrix that has three components. It consists of proteoglycan, which gives cartilage its compressive strength and contains water, which is water being the second component. And the third is type 2 collagen, and that gives cartilage its tensile strength. And so when we're thinking about osteoarthritis, we know that there's damage to the extracellular matrix. there's different fragments of those extracellular matrix components that we can measure. And there's also the release of these cartilage degradative enzymes from macrophages, which potentiate that damage further. So all of these fragments we can actually measure in the biological fluids of our patients, whether the synovial fluid, blood, even saliva sometimes of our patients as well. And when we're thinking about using these biological markers in the context of someone's disease, studies have shown that some of these biological markers, you can actually see higher concentrations of them earlier in the disease course of someone with osteoarthritis, even before they have X-ray findings of osteoarthritis. So with that knowledge, and I'm a PM&R physician, a lot of my focus is prescribing efficacious exercise regimens for patients, whether they have osteoarthritis or not. And so with that knowledge of sort of the pathophysiology of osteoarthritis I've described, and I want to talk about how we use that in prescribing exercise for our patients. So the current recommendations for exercise in individuals with osteoarthritis is greater than 30 minutes of moderate intensity activity 5 times per week. Now, that prescription is based on cardiac health. We actually don't know whether that prescription is actually beneficial or not to individuals with knee osteoarthritis. So the first study I did in this realm was actually to look at a nationally available cohort called the Osteoarthritis Initiative. And this is a cohort of individuals with osteoarthritis or at risk of osteoarthritis who are being followed nationally at 4 different centers. And there was a sub-cohort of these individuals where they were actually looked at their physical activity at baseline using pedometers. And we also had baseline demographics on these individuals. Now, what we were interested in was at 4 years down the line, what factors may be associated with radiographic progression of osteoarthritis from baseline. What I mean to say is that if you think about an individual at baseline having mild osteoarthritis on a radiograph, what factors were associated with them progressing to moderate knee osteoarthritis on a radiograph 4 years down the line? And for those of you in this area of osteoarthritis research, the factors that we found were associated with progression aren't going to be surprising. Being older age at baseline, being female, having a higher BMI, and having higher baseline pain were all associated with radiographic progression of osteoarthritis. Factors we found that were not associated with progression was actually physical activity, either at the lowest or the highest tertile of physical activity, having a prior knee surgery, or a prior knee injury before being included in the study. So overall, this suggested that physical activity, at least in this cohort, was safe in terms of progression of osteoarthritis. Now, of course, the big limitation here being is that this looked at X-rays, not MRIs in terms of cartilage thinning. The other thing that I often get asked by patients is, well, is there something that can regrow my cartilage? Well, I do some of those procedures, some of those orthobiologic procedures, but exercise has shown to be beneficial biologically for individuals with osteoarthritis. When we advocate for weight loss, there are studies that have actually shown that a diet and exercise intervention over 18 months actually decreased joint contact forces and inflammation in these individuals, which had some tie to improved symptoms in individuals with OA. A study out of Finland actually showed a progressive aquatic resistance program over 16 weeks on MRI actually improved the biochemical content of the cartilage, which also had some ties to improved symptoms and gait speed in these individuals. And finally, physical activity from the same group that they followed over 12 months physical activity, and they monitored these individuals. The individuals that were doing the most physical activity, so the highest tertile, actually had regional increases in their extracellular matrix constituents, which had ties to improved global function and cardiovascular fitness. So overall, exercise can have some biological effect in osteoarthritis that could be very beneficial. So with that knowledge now, and I've shown some studies which shows that there are some biological benefits of exercise, how do we utilize this knowledge to then assess an individualized response to an exercise regimen? So my lab has been spending the last few years to try and develop a cartilage stress test. This is the idea very analogous to a cardiac stress test. In a cardiac stress test, you get people to walk on a treadmill. You look at EKG changes to stratify risk for the development of osteoarthritis. Similar to that, we're trying to develop a cartilage stress test. This is where we get people to exercise, so we load their joints, and then we measure some of these biological markers. They could be markers associated with breakdown of cartilage. They could be inflammatory markers as well. And we try to infer how that particular exercise is impacting their knee joint by that acute response, biological response to loading. This idea actually came out of Stanford, where they did the first study in this realm, where they got people to walk on a treadmill for 30 minutes, and they looked at a serum biomarker response, that marker being COMP, which I'll talk about shortly. And that acute increase in that biomarker that they saw was actually predicting cartilage thickness 5 years down the line on an MRI. So the first study that we did in this realm was actually comparing two different exercise regimens where we would get people to walk continuously on a treadmill for 45 minutes. And then we ask them to do the same regimen where they'd walk in an interval walking approach for the same duration, 45 minutes. But there were 2 rest breaks of an hour interspersed within those 45 minutes. The marker that we looked at was this marker called COMP, and this marker is probably the most mechanosensitive marker in terms of exercise, and it holds together collagen type 2 fibrils. So every time you take a step on your joints, it actually transduces that mechanical signal from the extracellular matrix to the chondrocyte, and we know that mechanical load is really important for chondrocyte health, so it helps transduce that signal. But what happens in osteoarthritis is that there's actually breakdown, as I mentioned earlier, of the extracellular matrix. And when you see this increased marker in response to loading, it's really analogous to an increase in cartilage stress. So first, what we looked at was when you walked continuously versus an interval walking approach, what were the differences in terms of joint contact forces that we see? So we walk continuously, which is the red line here, and the blue line is them walking in an interval walking approach. There was actually a significant increase in the joint contact forces when they walked continuously on the treadmill, as opposed to the interval walking approach. When we looked at then gait metrics, there were differences in the speed at which they walked. It actually decreased when they walked continuously. And there was a change in stride length to keep up with the treadmill when they walked continuously for 45 minutes. And when we looked at that serum biomarker, there was a significant increase when they walked continuously, which was not seen with the interval walking approach. And there was also a significant increase in joint pain when they walked continuously. What this study really showed us was that when I'm prescribing an exercise regimen for a patient, I'm usually telling them to walk 30 or 45 minutes. But here, they were still getting the same cardiac benefits, and they actually more likely to keep up with this exercise because their joint pain was not increased as a result of that exercise when they walked in an interval walking approach, as opposed to walking continuously. So they may actually keep up with this exercise when you try and stratify the exercise you're prescribing. Now, I was debating whether to keep this study in or not, but I think it's important because we're obviously dealing with an older population here, and many of them are golfers. So I'll talk about that in a minute. But when we first presented our study at a national conference, I was actually approached by one of the golf authorities from the UK, and they were really trying to show the health benefits of the sports across different populations. And so they wanted to do a study where they wanted to look at whether golf could be an exercise in individuals with knee osteoarthritis. Now, when they were thinking about this, they were really thinking about it from a European perspective, where golfers usually walk the course. And the knee osteoarthritis population is a perfect population maybe for golf, in that the patients that I see, they don't want to exercise because they're worried about worsening their disease, but most importantly, they're worried about provoking their symptoms, whatever sport or activity they're doing. And maybe golf is the perfect solution. 17 people above the age of 50 play golf in the United States. Average distance they walk that they've measured, studies have measured, is 7 kilometers, with greater than 10,000 steps. And when I was thinking about developing this study with my collaborators, we were really thinking about how do we appropriately prescribe golf for individuals in knee osteoarthritis if this is the exercise prescription. The really interesting thing in the UK is that you can actually prescribe golf golf club memberships or golf club rounds for individuals with different pathologies as an exercise intervention. I don't think that will ever take off in the US because I don't know how to do a peer-to-peer for something like that. But that's just something very different in Europe and particularly in the UK. But when the collaborators were talking about doing this study, one of the major issues that they didn't think about in the US is that golf is played very differently. In that golf here is predominantly played with a golf cart. In 2006, they actually did a study where they looked at the number of rounds in the US and how they're played, and 69% of rounds were played with a golf cart. And there was actually a study from the National Golf Foundation about golfers and their body habitus. And they actually found that if you play golf, you're actually more likely to be overweight or obese than the general population. So I apologize to golfers in the audience today. But the unique aspect of doing this type of work in the US is that this actually gave us a way to maybe look at different types of exercise prescription, and golf being that prescription. So what we were interested in looking at, if you think about a golfer and you think about prescribing them golf, that walking the course is higher dose walking and using the golf cart is lower dose walking. So when we think about prescribing it, we wanted to look at these two interventions and how individuals did. So we wanted to compare higher dose walking versus lower dose walking, walking the course or using the golf cart. And so what we did, we looked at individuals before at the 9th hole and the 18th hole, and we measured continuous heart rate and step count data during the rounds. And what we also looked at, we took blood from them at these different intervals, and we asked them their joint pain. When you think about the cardiovascular findings, when you walk the course and individuals are on the course for about 4 hours, irrespective of whichever regimen they did, when you think about moderate vigorous intensity exercise during those 4 hours, about 73% of the round when walking the course was at that level, whereas 34% was when using the golf cart. But that's still about an hour of moderate intensity activity that these individuals were doing, which easily fulfilled daily physical activity guidelines. What we also looked at was pain and inflammation. As you can imagine, when they walked the course, there was a significant increase in joint pain in these individuals at OA that we didn't see when they used the golf carts. And there was also a significant increase in TNF alpha, which is an inflammatory mediator, only when they walked the course. And there was also, interestingly, an anti-inflammatory mediator increase when they used the golf carts that we didn't see which is IL-1RA, which we didn't see when they walked the course. But the only thing our players actually cared about was what was their score and how did they do. And their scores, 90% of their scores were better when they walked the course. So this study really showed that golf, whether irrespective of whichever way you play it, is maybe a good sport for individuals with osteoarthritis. And particularly when you walk the course, you get a better cardiovascular benefit. But in terms of that systemic inflammation and joint pain, it's definitely better to use the golf cart. So now I've talked about maybe applying this in a real world situation and a real world sport. Now I want to talk about stressing the system. And an area that I see a lot of in my clinic is post-traumatic osteoarthritis. So these are individuals who've had an ACL rupture, ACL, and then ACL reconstruction. And a lot of my patients will ask me, should I have surgery or not? And sadly, whether you have surgery or not does not seem to preclude you from developing osteoarthritis. We know greater than 50% of individuals with ACL tears or ACL reconstruction develop post-traumatic osteoarthritis within 10 to 20 years. And there's really no definitive treatment that prevents or delays the development of osteoarthritis in these individuals. So what we know is that there are studies looking at the acute phase after someone tears their ACL, and we know what's happening biologically. Then there's this sort of quiet phase from 2 years on to about 10 years where the patients don't have any joint pain, but there's not a lot of studies actually looking at them biologically, what's happening in their knee joint structurally as well. And then we know at that 5 to 10 years, more to 10 to 20 years, these individuals start having symptoms of osteoarthritis. So using that knowledge and many of the things I've talked about before, can we develop a test in unilateral ACL reconstruction that can provide us information on the biological state of the joints and how in turn that joint is going to respond to loading? So taking that cartilage stress test further, we're now trying to develop it or apply it to individuals post ACL reconstruction. On the left here is an individual just walking flat on a treadmill, but on the right is actually that same individual walking on that treadmill, but it's now tilted. So we've developed a treadmill where instead of an anterior posterior incline, we actually have a medial lateral tilt up to about 10 degrees. What this means is when you get people to walk on a treadmill flat, you can't really have a different type of loading pattern on each individual joint. They're essentially getting the same loading pattern. But when you tilt it, one joint is actually getting a different loading pattern compared to the other joints in trying to walk on this treadmill. So some of our preliminary studies actually showed that when the knee that's tilted towards that side, so if you think about it being tilted more towards the left side, the left knee in the knee frontal plane actually has the biggest biomechanical change as opposed to the other joints in the lower extremities that we see here. So there is a difference in the biomechanical loading pattern depending on which side you tilt it towards. So what we looked at in this study was actually to look at how whether you tilt to one side, which is the ACL reconstructed knee, and then you tilt it to the contralateral knee, which is a healthy knee or non-injured knee, what is the difference in biomarker response to that acute loading? And what we found was that when you tilt it towards the ACL reconstructed knee, there was actually a significant increase in that serum biomarker comp that we didn't see when you tilt it to the contralateral knee. When we looked at other markers, and there were some changes associated with inflammatory biomarkers as well that we saw in these individuals. But when we then tried to correlate it to a specific change in the knee adduction moment, the knee adduction moment is actually a biomechanical measure which is actually most associated with osteoarthritis development and progression. We actually found that the ACL reconstructed knee, the more adduction that it went into, you actually had a higher amount of a serum biomarker response, serum comp response. So the more adduction they went into, the higher the amount of that serum biomarker increase that we did see. So this overall showed, and then when we looked at metabolomics in these individuals, we actually found that there was a different metabolic profile in the contralateral knee compared to the ACL reconstructed knee. So there's something metabolically different that you were able to tease out when you tested the ACL reconstructed knee as opposed to the contralateral knee. So these study findings was that using this treadmill, we were actually able to differentiate the ACL reconstructed knee compared to the contralateral knee by the extracellular matrix markers and the metabolic profile. But the important thing to remember is that these individuals did not have any joint pain and they had no self-reported limited function. So it was only the biomarker differences that were able to tease this out. And so with that knowledge, maybe we could use this treadmill for early intervention to earlier identification. So now I've talked about maybe using these biological markers as a means to earlier diagnose osteoarthritis, particularly in a population we know is going to develop osteoarthritis. Now I want to talk about using it to assess a treatment effect. So one treadmill that we have that many of you who work in rehabilitation may have access to is this anti-gravity treadmill that's called the lower body positive pressure treadmill. This treadmill essentially works on air pressure that actually is the individual is running or walking within a chamber, and there's positive air pressure pumped into this chamber that raises up the lower extremities. And this is commonly used in individuals post-ACL reconstruction, but it's not very much been used in individuals with osteoarthritis. And so what we wanted to do, our first study in this realm, was actually to look at how does joint loading impact these individuals with osteoarthritis when we vary the amount of body weight support they have. So we wanted to compare when they walk at their full body weight or 100% body weight compared to where they're offloaded at 50%. And we wanted to look at how that impacts joint pain and also how that impacts some of these serum biomarkers associated with osteoarthritis. So the first part is when we're thinking about the intensity of the exercise, we wanted to see when they walk at 100% or walk at 50%, was there a difference in the level of moderate intensity activity that they had? And there was no significant difference in the amount of moderate vigorous activity they performed in these two regimens. What we looked at then was to look at joint pain. And so what we found was the amount of joint pain which they had significantly increased when they walked at 100%, so their full body weight, as opposed to 50%, which is the red line here. What we then wanted to look at was, what about that marker associated with cartilage stress? And it only went up when they walked at their full body weight, but did not go up when they walked at 50% their body weight. And then when we looked at their gait pattern on their biomechanics, we wanted to see what were the differences between the two regimens. So on the left here is when someone walks at their full body weight, and on the right is when they walk at 50% their body weight, and it's the same individual. And what you'll notice is that on the left here, when they're walking at their full body weight, they're almost walking with a very narrow base of support. They walk with one foot in front of the other. Whereas on the right here, they walked with their legs side by side. And that's a much more normal gait pattern. Now, they do walk slower at the 50% body weight, but they definitely do walk with a better base of support. So when thinking about a fall risk for individuals with osteoarthritis, the person on the left here is definitely at a higher risk than the person on the right. So with that, and this really then leads into the Pepper pilots that we did, was then to see if we could do a randomized study comparing the lower body positive pressure treadmill, so the anti-gravity treadmill, compared to pool walking. When you're thinking about walking in a pool, the buoyancy of the water also lifts up the lower extremities. And so maybe we wanted that as a natural comparator to the treadmill. And we wanted to compare it to a group that just received exercise recommendations, but did not receive a formal intervention. So this was a randomized study where we had individuals. The goal was 15 in each group. We actually ended up randomizing 49. And these individuals would get, the individuals in the control group would get weekly pain score surveys. And the two exercise intervention groups, individuals would come for 2 sessions per week for 8 weeks. They were randomized into these groups, and then there was a baseline assessment, a 4-week assessment, and an 8-week assessment. There were no dropouts that were felt to be study related. Most of the dropouts were related to logistics or other unrelated health issues as defined by our safety officer. And there were no dropouts from the 4-week time point to the 8-week time point in this study. In terms of demographics, there was no significant difference in terms of baseline demographics between these 3 groups. What we found was exciting for us in that we found that the blue line here is the anti-gravity treadmill or low body positive pressure treadmill. And we actually found that there was a significant increase in KOOS pain score. So the higher the KOOS pain score, the less pain they had actually on this metric. And there was actually a significant increase compared to baseline in these individuals in the anti-gravity treadmill group that we didn't see in the other 2 groups. The study was designed to look at within group differences because of the small sample size. But in this metric, we did compare in post-hoc analysis between groups, and we also found that the increase was significantly higher in the anti-gravity treadmill compared to the other 2 groups. When we looked at the other 4 metrics associated with KOOS, which is a metric outcome measure associated with osteoarthritis, we found that there was significant improvements in activities, sports, and quality of life that weren't noted with the other 2 groups, only noted with the anti-gravity treadmill group. When we looked at improvement in the 6-minute walk test, again, that group was the only one to have a significant improvement that was not noted with the other 2 groups. We also looked at gait analysis. We looked at baseline and then compared it at 8 weeks. So we looked at those metrics associated or vary in osteoarthritis. We looked at abduction, adduction, and we looked at the degree of flexion and extension these individuals had while they're walking on a treadmill. And what we found was that when we looked at change in abduction, adduction angle compared to baseline during walking, there were some trends, but particularly in the lower body positive pressure treadmill group, that we didn't see in the aquatic group and the control group in terms of abduction, adduction. And interestingly, in flexion extension, we saw that there was an improvement with the lower body positive pressure treadmill. There was also an improvement noted in our control group, which we're trying to actually make sense of with our study. And maybe the next slide may give us a sense of that, in that what we wanted to see was what mediates the improvement that we see in symptoms in these individuals who are in the anti-gravity treadmill group. And we found that the change in abduction-adduction angle was not a mediator of improvements, but the change in flexion and extension angle was a mediator of change in KOOS pain that we didn't see in the other two groups. So there was an association between that change in flexion extension, or an improvement in flexion extension that individuals had in the anti-gravity treadmill group. That may be the reason that we see some of the improvements. But obviously we can't elude causation because of the small sample size we have in these groups. Finally, we also wanted to look at some of these inflammatory mediators and how that changed at 8 weeks following the intervention. And the only group, when we look at pro-inflammatory mediators, that had an increase in that systemic inflammation was the control group. In the exercise group, there was no significant increase in systemic inflammation, particularly in IL-1 beta, which is one of the most commonly associated biomarkers or inflammatory cytokines associated with osteoarthritis. Interestingly, when we looked at anti-inflammatory biomarkers, in particular, we looked at IL-1RA and IL-10. With IL-1RA, there actually was a significant increase, which mirrored to some extent the increase in IL-1 beta, which probably suggests that the increase in IL-1RA was as a response to an increase in that pro-inflammatory mediator. So in conclusion, with this study, we really found that offloaded walking therapies, maybe there is potential to have them as part of knee osteoarthritis treatments. Our future research is really to assess the long-term benefits of this in a longitudinal randomized controlled trial and really comparing it to standardized treadmills. And we're also exploring cost effectiveness. This is a very expensive treadmill. We are assessing, working with the company to develop, they are developing a cheaper version of this treadmill, but also we're planning to, in our institution at least, to have a in-person low-cost version of assessment of individuals for this treadmill. For example, individuals pay a nominal fee such as $10 to $20 to actually use this treadmill as part of their exercise regimen. So finally, I know I've gone through quite a bit. I really want to segue into targeting interventions to individuals at the right time. We've talked about early intervention through early diagnosis. I've talked about the use of some of these biological markers to assess an outcome of a procedure. But now I want to talk about targeting individual treatment and really individualize or personalizing our approach to treatment. When we're thinking about targeting treatment, some of the work in my lab, which I'm not going to go through, is that we've done some studies looking at factors associated with outcomes, whether it's physical therapy or injection treatments. And there's studies certainly that have shown from our lab and others, the demographic, socioeconomic status, and patient expectations are tied to outcomes of whatever treatment you're planning to do. But one thing I was interested in, particularly with injection treatments, is does the environment that you're injecting your whatever medication into impact the outcome of the injection? And if there are any Pepper scholars on the call right now, I highly encourage you to apply for the Pepper Visiting Scholar Program. It really was, and I'm not overstating this, it was really a career-changing experience for me to get to go to Duke University and work with Dr. Virginia Krause, who's one of the leading experts in particularly biomarkers of osteoarthritis and a rheumatologist by background. She actually introduced me to an individual who's the head of the proteomics core there, Eric, who's also helped us significantly with a lot of the research that I'm going to present right now. But Dr. Krause really gave me a lot of we had a lot of fruitful discussions on my research and also some of the biomarkers and how best to utilize them in my research as well. So the study that we were interested in doing was actually looking at what factors were associated with outcomes of injections, which we commonly do in our clinics. And so what we wanted to see was pre-injection and then post-injection, what factors were associated with change in KOOS, which is that outcome metric for osteoarthritis. So what factors were actually associated with these outcomes from either clinical or synovial fluid biomarker concentration. So we compared two different kinds of injections, and I mentioned them at the beginning. We looked at corticosteroids, which are probably the most ubiquitous injection that's done for osteoarthritis. They're anti-inflammatory, and it really takes 3 to 4 weeks to see an improvement in symptoms. And similarly, not similarly, but hyaluronic acid is another injection that's commonly used in osteoarthritis. This has an anti-apoptotic effect on chondrocytes, and studies have shown really at 4 weeks is when you're seeing the maximal improvement in outcome with this injection. So what we wanted to do, we got these individuals pre-injection, they filled out the baseline KOOS survey, and during the injection, I do ultrasound guided procedures, we aspirated their synovial fluid during the injection. And they were either undergoing a steroid or hyaluronic acid injection. That was decided by their physician, had nothing to do with us as part of this study. But what we did was these individuals then had their 4-week KOOS score taken, and we had 26 in one group and 25 in the other. When we looked at outcome of the injection, we saw that there was really a difference. The steroid, at 4 weeks, there was a significant improvement with the steroid injection that we didn't see with the hyaluronic acid injection, which is a little bit disappointing to see because it's such a common treatment that we give our patients. When we then looked at synovial fluid analysis, we found that there was difference in terms of the type of biomarkers or proteomics in the synovial fluid between these two responders between these two injections. So responders to the steroid injection tended to have more inflammation and tended to have proteins associated with the complement pathway. Whereas responders to a hyaluronic acid injection in their synovial fluid, they had more cartilage degradative markers and less immune-mediated markers that we saw. What we then looked at was, well, what about the clinical metrics? How predictive were they of being a responder or a non-responder to the injection? And BMI was actually most tied to there being a responder with the steroid injection. But then when we included proteomics in our model, we actually found that none of the clinical metrics actually were as predictive as compared to the proteomics analysis that we've performed. So clinical metrics were certainly less related to outcomes as opposed to the proteomics evaluation that we did as part of this study. Then we wanted to look at, in terms of machine learning, we were interested to see, can we actually create a predictive model in these individuals? So on the top here, the F1 score is actually a marker of how reliable your model is for actually being predictive of response to an injection. And then accuracy is obviously how accurate that model is. And so when we looked at the best logistic regression model in terms of just purely using clinical metrics, it was less than 50% predictive. But then when we actually included our proteomics, we were actually able to increase this model accuracy and by about 30 to 40%, which is pretty exciting to see. When we then looked at the hyaluronic acid injection, you can see that it was much less than a 50% predictive when you actually purely use clinical metrics, which is what we're doing now in our clinics. But then when you looked at proteomics, you again were able to improve it by about 30 to 40%. Now, obviously, this is a small sample size, and we've applied for grant funding for looking at this in a larger cohort. And the next step is really to look at serum or blood analysis, because you're never going to just take synovial fluid from a patient and then tell them which type of injection they should have. You're rather going to look at, you may take a blood test from them and then be able to create a model that tells them how likely they are to respond to a particular injection. And we saw a similar response with hyaluronic acid, as I mentioned as well. So in closing, I've presented a lot of data that we've been doing the last few years in my lab. My goal in terms of osteoarthritis treatment as a physician scientist in this area is to really personalize the experience of our patients by still examining our patients, performing imaging studies, but also utilizing and responding to psychosocial factors, biological markers, and biomechanics in our patients, and really trying to treat every patient as an individual to really optimize their response. I really want to thank my lab at the Shirley AbilityLab. I have a small but mighty group. I also want to thank my mentor, in particular, as part of the Pepper Scholar Program, who's Dr. Leah Welty, who I still meet with on a monthly basis and has been really phenomenal for so much of the research. And I really want to thank the Pepper Center for supporting our work. And it's really been, as I said, a career-changing experience for me. Thank you so much.
Thank you so much, Prakash. That was great. I mean, brought up so many important things that are so crucial for so many of our patients, and how can we best individualize and set expectations about who's going to benefit from what treatment and procedure. It's just so important. If anyone has any questions, please put them in the chat. That was a great talk. Let me just see here if I see any questions. Don't hesitate to put those in the chat for us. I thought it was interesting that when you offloaded the joint, they walked slower.
That's right.
They
Yeah.
were getting used to it. You would think it would be easier to walk faster.
That was one of when we submitted it, we just got accepted for publication, and that was one of the reviewers were like, "Why can you explain that?" And we just couldn't. I think there might have been a little bit. This was just one visit that they were coming in for, so there might have been a bit of apprehension when walking at the 50% body weight. That may have been more what it was associated with, rather than purely a pain-related change. So that's what I'm not certain of. But it was hard to explain that because all the studies show that when you're it slightly goes against what we would expect. You typically, if you're feeling less pain, you should walk faster.
Well, despite walking slower, they still had benefit from it. So that's
Yeah.
the important thing. Here's a question. Any thoughts on the ramifications of the GLP-1 receptor agonist?
Yeah, I think one of my collaborators is doing a clinical trial on that, and the early data does suggest that there is definitely a decrease in systemic inflammation, and there is an improvement in joint pain as a result of that, and probably related to the weight loss as well. I I I guess I worry a little bit from an OA perspective, just because I worry that individuals will utilize that rather than exercise as a treatment for osteoarthritis. And exercise has, particularly in this population, has so many systemic benefits. And it's really beneficial for the OA, but it's beneficial in other ways. So I think one study I would be really interested in is using that as a stepping stone to then getting back into exercise. And I think that's not the way that it's being prescribed right now, at least from a OA perspective. And I would love to see maybe a study which uses it as a way, which is actually what the clinical trials we're planning to do with the treadmill. For example, I'm not anticipating people are going to use the anti-gravity treadmill lifelong, but a short dosing burst for 8 weeks at the beginning, and then seeing if that allows them to then exercise in the community would be really, really great. Last thing I'll just say, we did do a focus group of the anti-gravity treadmill. I know this is not the question, but we asked individuals at the end what they thought of the treadmill. Many of the ones, particularly in the anti-gravity treadmill group, felt that it allowed them to then, as a stepping stone, to then get back into exercise in their everyday life. And I think the GLP-1 receptor antagonist will be similar, and I hope that that's the way it's utilized in the future.
It's not either or, it's both.
Right, exactly. And people still eating healthy and doing other things that they need to do.
That was a good question, though.
Yeah.
Other questions from the audience? Well, I'm not seeing any, but Prakash, that was really excellent. Thank you so much for coming and speaking to doing our pepper rounds, and we're so proud of you, and can't wait to hear what's next. Can't wait to have you come back.
Oh, thanks so much. Thanks, Sarah, and thanks for all the support to you, Mike, Jeff, everyone in the Pepper, Giselle, everyone in the Pepper program. It's been super helpful.
And thank you everyone for joining us today. We'll look forward to seeing you again next month or sometime soon.